We would now move on to the next lecture, please. Dr. Surender Dabas.
So just skipping the anatomy of larynx. So we know the site of cancers in larynx, the most common is glottic area, the second is supraglottic area, and then the subglottic area. So now the treatment option in larynx, we started with open surgery. It was laryngectomy before we started with partial laryngectomies. Then we came to chemoradiation. And then we talk about laser surgery. Now we're talking robotic surgery. So the motto of the treatment in larynx was good functional outcomes and good oncological outcomes. So why we left doing open surgery or total laryngectomy? Just because of organ preservation. And we were talking about only organ preservation. We were not talking about functional preservations, which is the most important aspect of treatment in laryngeal cancers. So now we proved with laser surgeries that the oncological outcomes are as good as with chemoradiation in larynx and with good functional outcomes. Now we have few fallacies in laser surgery which can be overcome by robotic surgery. Now the robotic system we have now, like XI system, they have some technical difficulty with this XI system, but maybe in future, maybe next 1 year later, this can be overcome by the single port system, which is a flexible system with all flexible instruments. Even the camera is flexible. So we're asking about the visualization of the subglottic area. The answer will be given by the single port robotic system in future with 4 arms inside, 1 for retraction, 2 working ports. So now we have to discuss between TLM and robotic surgery, which is better, and what are the technical advantages of doing robotic surgery in supraglottic cancers. So type of laryngectomy we discussed, type 1, type 2, type 2A, type 2B, type 3, A and B, and type 4. So a lot of things are there. Type 1 is very easy, like an tip of the epiglottis is involved with tumor. You can go for surgery, resect the tumor. May not be, you need a neck dissection in these cases, very early cancers. Maybe a small tumor on AE fold. So you can go for laser surgery or you can go for robotic surgery. But when you go for advanced supraglottic laryngectomy like type 2A and type 2B, we are resecting, like type 2B, we are resecting the full epiglottis up to the base. Then the view, the magnified view of robotic surgery as compared to laser surgery is much better. You can manipulate the tissue and you can do an en bloc resection of the laryngeal surfaces. Like in type 3, type A and B, you are doing a resection of pre-epiglottic space. Very easy to manage with the robotic instruments as compared to laser. You have a good view, better view, magnified view, and even the endoris instrumentation of robotic instruments is so nice that you can handle the tissues very well. En bloc resection with good margins. In laser you have straight view, but in robot you can have a different view. You can move your camera on left and right and have a better view. Type 4, again you have seen a video in the morning shown by Dr. Karan, and supraglottic laryngectomy in a salvage patients. Resecting the epiglottis, AE fold, going up to the ventricular fold, taking out the retinoid cartilage. So I will say lateral laryngectomies, and you can do the medial laryngectomies also. So now handling the tissues again is better as compared to laser. So it's not about how you do the surgery with robot. The training part, if I'm a laser surgeon and I want to train someone, it's very difficult for me to train someone in laser. But in robotic surgery, the training is much easier as compared to laser. So now for future, if you want to go for surgery in laryngeal cancers like supraglottic larynx, your training part should be easy. So now we know the resection part is better, but the training part is again better. So I can say if you teach your fellows or resident maybe around 10 supraglottic laryngectomies, starting with type 1, going to type 4, you can make them better surgeons in robot as compared to laser. So these are the technical advantages of robot over laser, like the precise tissue manipulations, superior depth perception because of the 3D view, 10 times magnified view, no line of sight limitation of laser, 7 degree of freedom of the instruments, no tremors, the tremors are filtered, motion scaling, it has an inbuilt mechanism of the robotic system, and a telesurgery, which is the future of surgery. For any surgery we can talk about, maybe a minimal invasive surgery, and robot is, in the next 5 years will be telesurgery in AI. And I've missed about training in this. Training is easier with robot as compared to laser. So now how we do that, we have seen in the morning in robotic supraglottic laryngectomy, FK retractor. I will say the best part of performing a successful supraglottic laryngectomy is selection of a patient. Second is you should have good exposure. So now you do laser or you do TORS, exposure is the one which is required for all surgeries. If you have a good exposure, you can do any surgery, but again you have to limit yourself, seeing the complication of your surgery like aspiration and swallowing outcomes. This has to be in mind when you are performing any surgery, either with laser or robot. So you need a good exposure in supraglottic laryngectomy, and FK is the one retractor which is always used for at least supraglottic, not for base ring and tonsil, but supraglottic is required. This is how the OR looks like for supraglottic laryngectomies. I'm not showing any video because we have seen the video in the morning, we have seen a lot of videos about this. But these are the technical advantages I'm talking about. Even you can put sutures, you can take a needle holder and start suturing the tissues in supraglottic area with robot, which is not possible with laser. So now in future you want to go more and more advanced in laryngeal surgeries. I think we need some instrument which can go deeper, good magnifications, good visualizations, and you can handle more and more instruments. Now we have to look for few structures like in laser, lingual vessels, supralaryngeal vessels, internal branch of superior nerve and hypoglossal nerve. So the visualization of these nerves is much better in robotic system because of the 3D view and magnified view. So you can save the structures. You can see the branches of interlaryngeal nerve and supralaryngeal nerve going inside. You can partially save the branches which are not going into that part which we are resecting. So because of this, the manipulation or a very well control on robot, you can save the structures. This will give you better functional outcomes. Now, the main part is when you want to do a supraglottic laryngectomy, oncology is one. Yes, you want to go for a margin negative resection, one. The second part is also very, very important. You have to be very protective in preserving the structures so that your respiratory and phonatory functions are better. And the main is base tongue resection should not be as wide because it will lead to aspiration and your outcomes will be very, very bad. So selection of patient is must. So now the inclusion criteria I was telling in my past 10 minutes before, T1 and T2 tumors, all T3 and T4 should be excluded. Only limited T3 tumors can be resected with pre-epiglottic space invasion and minimal base tongue involvement. These are all the same slides. So now we compare laser versus robot in terms of complications and outcomes. So the complication of any surgery like laser or robotic is same. The intraoperative, like we don't have a good exposure, bleeding, premature extubation, airway fire. Same. Early postoperative complication are airway obstruction, swallowing dysfunctions, hoarseness and bleeding. And late complication like swallowing dysfunctions and laryngeal strictures. This can happen with any surgery, either laser or robotic surgery. But again, if you select your patient very, very wisely, the complication can be minimized. And this is the main motto of our treatment in doing a conservative surgery in larynx. Now this is the outcome of oncological outcomes of many, many studies in robot for supraglottic laryngeal cancers. So now depending upon your expertise or your experience in performing the robotic surgery in supraglottic cancers, you can go for negative margins in around 60 to 100% of patients depending upon your experience. But because of nodal status, most of your patients will require either adjuvant RT or chemoradiation. At least 40 to 70% of patients are receiving adjuvant treatment. Now we are comparing laser and robot. Basically, I will say we should look for local control as compared to total overall survival and all this, because we are just doing surgery for either with laser or robot for local cancer. So the local recurrence is 0 to 11%, and the overall survival is from 67% to around 89%. So this is true for either we do a laser surgery or do a robotic surgery. We don't improve the survival with the robotic surgery, but we improve the functional outcomes. So this was our paper 5 years back when we started doing supraglottic laryngectomy around 7-8 years back. And this was basically for our patients who were SPV negative or of supraglottic cancers. And we said the margins was around 5 mm, but we have to reselect the margins sometimes, which is easier with robot as compared to laser. And most of the patients were T1 and T2, no T3 tumors were selected. And around 84% patients were alive when the last follow-up was done. So the oncological outcomes are equivalent to laser surgery. Again, I'm saying the functional outcomes are better in terms of your selection, and you were resecting the tissue with good margins and not comparing the functional outcomes. Now, total laryngectomy can be done with robot. My experience is very limited. Till today, I've done only 3 cases with robot or total laryngectomy. Selection of patient is very must. Like for T1 and T2 tumors, which were chemoradiated earlier, now you want to salvage the patients. And they were not amenable for partial laryngeal surgery like glottic resections. So in these cases, you can go for laryngectomy, total laryngectomy by few flexible system, like we have Med robotic system is a flexible system for this. With XI, I have done 3, but it's not easy. But out of 3 patients, 1 patient leaked, and then I stopped doing laryngectomy by robot. So I still prefer to do by open method. Maybe in future, once we have an X single port system with more instruments, flexible instruments, I can go for laryngectomy total with robot, because technically is a good technique. The leak rate are less as compared to open surgery. But we face difficulty in performing laryngectomy with present robotic systems. And same is with glottic cancers, like Dr. Parity was telling about laser surgery in glottic cancers. Till today, I have not done any single surgery for glottic cancers. And maybe without single port system, I will not perform it, because exposure may be good, but your instruments are bigger. And your resection part will be bigger and leading to more morbidity. Maybe with flexible system, which are coming as 6 mm instruments with finer tips, you can go for robotic surgery in glottic cancers rather than laser surgery. But till today, we don't have an evidence for glottic cancers by robot. Now the last part is hypopharynx, which is the most difficult part to handle and the most dangerous part in all of the head neck cancers because of the submucosal spread. So you can go for good margins, but still you can have very bad recurrence. The recurrence rate may be up to 40% in your hypopharyngeal cancers. So whenever you plan surgery for hypopharynx, you select very, very small tumors, like posterior hypopharyngeal wall, or maybe PFS tumor, maybe in the lateral wall, not going to the apex. So now if you are selecting a patient of PFS going to the apex, and you are resecting it, you can resect it, but the morbidity will be high. You can have stricture, post-cricoid stricture. Your voice quality will be bad. Aspiration chances will be high. So you have to select piriform sinus tumors very, very correctly so that your functional outcomes are better. So in hypopharynx, if you see the series, I will show you the series. See the number of patients, how many people have done till today. 5, 5, 10, 3, 38, 57. So highest number is 57. And then you see the recurrence rate and see the survival. So survival is not because of your surgical technique. It is because of the hypopharyngeal cancers, which have a high tendency of submucosal spread. But when you see the recurrence rate, in a longer series, the recurrence rate is still high. But if you see the morbidity is still more high. So I speak about if you do laser surgery for hypopharynx or you do robotic surgery for hypopharynx, the results are not so good. Even with radiation, the results are very bad. So if you select your patient again correctly, small tumors, you can give them better functional outcomes, even the oncological outcomes will be better. So there are a lot of papers about how hypopharynx in when we do TORS or we do TLM, and the results are like 5-year ORR survival is around 45%. So now there is a new technique in hypopharynx, which is basically promoted by Japanese people, and we say that is ELPS, that is endoscopic laryngo-pharyngeal surgery, and we say TOVS also. They do with specific flexible instruments, but they select very superficial spreading tumors. They are not taking the tumor going into the muscles. They have taken the submucosal or mucosal tumors only, not the tumor going into the muscles. So maybe for laser or for TORS, we are selecting the tumors maybe going outside the muscle area, but for ELPS, they are selecting only superficial mucosal, submucosal tumors, and they've shown the results are much better than TLM or with robotic surgery. But again, selection bias is there in these patients. And now you compare TORS versus ELPS. Both have complications. But the complications are different. Like for TORS and ELPS, if you compare the bleeding, it is more in ELPS because your control is not as good as with robot. You can see the vessel, you can clip the vessel, but it's not possible with these instruments. Then you see the aspiration pneumonia is more with ELPS as compared to TORS. But the swallowing difficulty is more with TORS as compared to ELPS. So these are few technical comparison between ELPS and TORS. But I am saying it is still, we don't have a single port system. If you have a single port system, flexible system, maybe new system, like a snake robot, then you can go for robotic surgery because your control is better when you're sitting outside and doing the surgery rather than you're standing with, or you're sitting with the patient and doing the surgery. So these are all how you handle the instrument, how you select your patients. So now we focus on functional and oncological outcomes. We need to find a technique which can give us better outcomes in both terms like oncology and functionals. So for supraglottic larynx, yes, I recommend robotic surgery for T1 and T2 tumors, very selected T3 tumors. Glottic tumors, I will say that it's still an experimental thing. For total laryngectomy, few centers are doing, results are better, but you need a flexible system, not the present exercise system of robot. For hypopharynx, very selected patient needs surgery, maybe by robot or by TLM or ELPS. The selection is, see, you cannot have 50 patients in 1 year. It is around 10 patients in 1 year. This is how rigid selection it is. But again, the functional outcomes are good if you do surgery as compared to chemoradiation. But again, you need a flexible system for this. This is all from my side, comparing robot versus TLM and how we can apply robot in all these areas. But still, this is the most difficult area for a robotic system to tackle with larynx, mainly glottic, subglottic, hypopharynx. Very difficult area to tackle with. Thank you so much.
Any question from the floor, please?
Surender, a very good talk. I have a question on your experience in salvage cases.
Sir, again, the same question was asked to parity about salvage glottic cancers. The answer is same like for salvage supraglottic cancers. If the tumor was resectable at the beginning, I will advise surgery. But I never do surgery when the tumor was T4, give radiation, it has become shrunken, small in size. You do surgery, it will recur 100%. So it is not a good candidate for that. So always when I, yes.
Maybe if it's a late recurrence, not like residual disease, if it's a late recurrence, like coming after.
Sir, again, like for epiglottic tumors is very less, A-fold less, but if it is involving epiglottis, A-fold going to the ventricular area, if you are going to the glottic area, the recurrence rate is very high. Going to PFS, again the recurrence rate is very high. And the functional outcomes, again we know that functional outcomes are not so good in salvage setting as compared to naive settings. But again, once you see the patient prior to chemoradiation therapy, you can decide this patient will require surgery in future or not. But maximum time you get a patient without prior information and it's coming once it failed on chemoradiation, then it's very difficult to decide should I go for surgery or not.
Thank you.
Thank you very much, sir.